on basic Social Security and you have $8,000 a year to live on and you have a high drug cost, then maybe you go back to eating cat food. So I'm not a fan of our system, but I have to work within it. So why mediation? Well, as my story demonstrated, yes, there was a principled bioethical issue at the core of that consult. And it was this: patients who are capable of making healthcare decisions have the right to consent to and refuse care when they're capable, and the right to appoint someone to make decisions for them when they're not any longer decisionally capable. That's the principled analysis. There was a strand of that in the case, but the case was really about conflict. And many, many of the cases in which we're called are about conflict. And the way to deal with conflict, if it swims like conflict and it quacks like conflict and it ruffles its white feathers like conflict, then I would argue to you it's helpful to think about it that way. Why? Because I can teach people how to do conflict resolution. Because there are skills you can learn. Just think about the following. A case I did the other day, a 32-year-old, profoundly obese man who lives with his dad, and his dad has neglected his care over the last years and now has a very serious cardiac condition that can be addressed by surgery, but it's very risky surgery. And so I get the call that says, patient's son refusing surgery. So I go. So consider these two discussions. Your dad really needs this surgery, and if you stand in his way, it will not be the best care for him. Does that sound reasonable for a physician to say to a son refusing surgery? Some variation. Contrast it with this. Thank you so much for being so involved in your dad's care and for loving him so much. We are always grateful when we have family members who care so deeply that they're willing to spend the time and the effort to help us think through what's best for this patient. Sound different? That comes out of what mediators call stroking. Get the person you're dealing with to feel not that they're an embattled other behind all these white coats, but someone who really cares. And this son did really care. And 2 hours later, we reached a point where he said he'd go back and ask his dad, and he thought maybe his dad would want the surgery. Now, there's nothing magic about techniques of mediation. The mediator works with the parties to try to reach a consensus. And mediators are optimists. I am an optimist. I always think when I come into a case that I can, in fact, bring the caregivers and the family, and it's usually the family, together on a care plan. I'll use time-limited interventions. We'll come back together and meet in 24 hours. I have the time to do this, to be there. You can't reach a consensus on a timetable. Sometimes when I meet first with the care providers, there are huge disagreements among the care providers as to what's happening and will happen. Well, needless to say, if all of those care providers are talking to the family, you have a very confused family because they don't bring to the table the skills to sort through those arguments. So what does a bioethics consultant who uses mediation and techniques of dispute resolution do in these cases? One, we identify the parties to the conflict. Two, We try to understand what's going on, both what's stated explicitly and sort of what's going on underneath. I forget what names I gave them. David and Mary. David and Mary had a history of not getting along, said one of the other sisters. And it is my finding that families with certain dysfunctional relationships, and none of us, my guess is, are in families without some tweak of little dysfunctional relationships, except for me, of course. Those don't get better under stress. And I have a particular pitch today because as I age, which I'm doing at an alarming rate, and as we all age, I want to argue to all of you as physicians, but also as patients, that this sort of intervention should be available at places. Not a bioethics consultant who comes in and tells what should be done, but someone who works with the parties, who levels the playing field. If you're here at a bioethics lecture at the Robert Wood Johnson Medical School, you're very savvy and connected. Most patients are not. And the patients I get in the Bronx are not savvy and connected. They're largely people of color and they're largely poor. And they're terrified by the setting that they're in and all of the people with white coats who come in and out when their loved one is so sick. I don't wear a white coat on the floor because I'm not a physician. And I don't want people to confuse that. So leveling the playing field, making certain that there's a room for the voices of the family and the patient in the hectic schedules of a medical center, helping parties to think what their interests are. So with David and Mary, I think what worked was the notion that their interests were somehow linked to their being together after Mom died, when it was clear that Mom was going to die. Now, this case was particularly complicated because David had said as an aside to the ER attending that if Mom died, someone at the hospital would pay. Well, that's the kind of comment that works its way up instantly to the Office of Risk Management. And I think that at the end of my time with them, when David said that he and his brother, who is an Episcopal priest, would begin to work together on Mom's funeral when that time came, I felt pretty comfortable, not totally, but pretty comfortable that we were okay. I'm always searching for consensus, both within the medical staff and within the family. And if that consensus is a small one, just a little bit of agreement, that's fine with me. I'll come back the next day and see if we can expand it. The process of feeling that you're working together encourages working together. And families and providers need to work together, especially when the patient is at the end of life. The vast majority of my consults are around end-of-life care, not all of them. And in fact, just as an aside, we type our consult notes. We have a consult, go back to the office. We write 3-page, single-space consult notes. Now, for those of you who've ever looked at a medical chart, there is no such thing as a 3-page, single-space consult note. And so when people find that in the chart, they stop to read it. And we use that note not only to talk about the case, but to teach. So let me give you an example. Just recently, I had a case of a young man, 25-year-old man, with very severe cerebral palsy and retardation transferred from a nursing home for care. And one of the issues was, well, should he be treated like any other patient? So I wrote a very long introduction. First, I said, we really don't know if this person is retarded, because 25 years ago, there were no ways of communicating with someone who was this disabled. So put that aside. Don't give great credence to it. I then went through the history of people with disabilities and how they've been treated by healthcare systems, including the fact that at some point in the Nazi terrorism of Germany, they killed people like this. And I used this as a way of moving toward, and this was a consultation, not a mediation, a consultation saying this patient has as much of a claim to our intervention in his best interest as any other patient. So I search for consensus within what we call a principled resolution. So for example, to come back to my presenting case, it would not have been acceptable to say, here's mom, she has a healthcare agent, we know what she wanted, doesn't matter, we're going to put in a trach and a peg and send her in this state to a nursing home. That would have been precluded by the ethical principles and legal rules that govern bioethics consultation. However, 2 days to let David be comfortable with the decisions. So a principled resolution requires that you work within an orbit that has been defined by law, medicine, and ethics, but with the notion of flexibility and with the notion of the importance of process. Flexibility. I am very flexible. My children want to know why I am gone from the house at 7 in the morning. Mom, you're too old to have these hours. And I say, but that's when I can meet with the care team. So that's when I show up. I don't have a lot of rules about how I relate to the care providers and the team at Montefiore. I have a lot of rules about the importance of process, about the importance of teasing out the issues, meeting with everyone, and working toward consensus. Now, here are the limitations of mediation. You can't work with caregivers, family, or patient who don't want to reach an agreement. So I now have a new system. If there is a family, and it happens occasionally, who is abusive to the care staff, will not listen, is very demanding, and interferes with care, and it's clear that there's nothing I can do to change that pattern, I take my chart note, I email it to the medical director of the hospital. I say, Gary, this one's yours. I can't do anything here. I can work with people who want to reach an agreement, but mediation doesn't solve all problems. Some families simply are too overwhelmed by what's happening with the patient to be able to participate. And sometimes I can go back after a while, but you can't mediate where people don't want to. So sometimes we use the distinction between bioethics consultation, which is a directed substantive process. Again, for example, if David had insisted that mom go to a nursing home on a ventilator, despite what we knew about her wishes, I would have had to write a consultation note saying, I can't mediate this case. Here are the principles that apply, and send it to the medical director. Some things have to be decided by the administration. I sometimes fall right on my nose. And families, I think usually there are histories in families who can't come together, but I'm not a psychiatrist, I'm not a psychologist, and I'm not a therapist. And if those sorts of skills or someone to set boundaries are needed, I can't do that. So bioethics consultation is a process but a limited process that identifies principles. Whereas mediation refers to the classical mediation techniques to identify, understand, and resolve conflicts. So let me come back to this notion of conflict again. Part of the way we think about conflict grows out of the fact that there are almost always choices in medicine. Some choices the physician will think are maybe not as great, not as good, some are better, but there are always, almost always choices. And what determines which choice is used as the foundation for a care plan relates to what the values of the patient and family are. Sometimes those values have to do with religion. When we have Orthodox Jewish families and patients, they often come with their own rabbi, who has very strong feelings about what is theologically required. I like to tell the story. I had a wonderful friend who died many years ago, Rabbi Baruch Boxer, who died when he was 42. It was a great tragedy. And he believed that, first of all, he wanted every minute of every day. And second, he believed it was his theological obligation to accept care. And the day, and I have the permission of his wife to tell this story, the day after he in fact had a cardiac arrest and was resuscitated, he wrote the word hope on a piece of paper. So what a patient wants is a critical element in what we try to mediate. There are almost always options, and the notion of mediation takes those options seriously and arrays them as a set of alternatives for care providers, family, and patients to consider. Why mediation? Because it's the least bad way of proceeding. Because if you have to make hard decisions, I would argue that making them in a way where people feel comfortable at the end, that they've done the best they can do together, is a good way to proceed. It's unique. Bioethics mediation is unique, first of all, because I am employed by the hospital. I am not a neutral in the standard mediation sense. However, I am neutral to this case, to these providers, families, and patients. But I am a repeat member. When I first meet with a family, I explain that I've been asked to come and meet with them because there appears to be some difference about care, that I come to mediate, but I am employed by the hospital for those who are used to, accustomed to, the notion of mediation as a classical neutral. And we talked about that. Deciding to reach a resolution is not an option. If you're a standard commercial mediator and the contractor built a new driveway for Mr. Harrison and the driveway collapsed, so Mr. Harrison wants money back from the contractor and the contractor doesn't want to give money back to Mr. Harrison. You know what? I'm sorry if they can't reach an agreement. One of them will be cross. But do I care deeply if they reach an agreement? I don't. But bioethics mediation is different. Here is a patient who is very, very sick. You either have to do A, B, or C, and one of those must be chosen. Reaching an agreement is not an option. And I think it's a shame that people would disagree about $1,200 if the driveway collapses. But that's not high on my list of the things that concern me in my little pursuit of tikkun olam. And the playing field is often uneven. Medicine is powerful. It's practiced in huge institutions. All of us who are here have friends and relatives who are physicians. All of us. That's why you're here. But that's not true for many of the population, and they feel terrified of and alienated from medicine. And my job is to try to pierce that in a way that helps people reach a timely decision that they in fact can live with. Life and death issues often play a role, and the patient is often not there. So I regularly begin my discussion with the family by saying, tell me about this person. Not what he or she wanted about medical care. Tell me, what did she do during the day, and what groups did she belong to, and what church, if she belonged to a church, did she go to, and what did she care about? And so we'll spend some time talking about this patient as a person, not as someone who is desperately ill in a hospital bed. And these are often multi-party events. I come back again and again if I need to meet with families. And finally, we become involved in follow-up. I will always call the next day or a few days later to see, has anyone been in touch with the family? How are they doing? Or where did the patient go and how is the patient doing? Often what we discover in bioethics consultation are themes that the hospital must consider. So, for example, it is unacceptable to have a dying patient in the emergency department for over 24 hours. So I email the medical director and say, there has to be a way of trumping the usual procedure to help a family be together at a time like that. Now, I know what's going to happen to the meeting that comes out of that memo. Everyone is going to argue, this is a dying patient. We have patients who need care. They need to go up there first. And we'll try to work out a set of priority and guidelines. And finally, we had a mediation about 2 weeks ago, an adolescent girl who'd come from a very far away place to New York and had, unbeknownst to her, been sold by her family to a man much her senior to be his wife. She had become extraordinarily ill, and we suspected had tried to commit suicide. And 22 people came around a table for 2 hours on a Thursday afternoon to see, taking all the wisdom we could gather from all of the people there, how we might help this child. We came together under the label of a bioethics mediation, and it was my honor to be part of that discussion. So thank you very much for coming today. Sure, of course.
Okay. We can take a couple of questions from the audience, and then following the questions, there'll be a reception on the 3rd floor of this building in rooms 3403-3404.
Please.
I'm very impressed with the work you do. I'm curious, on a national scale, how common, and is this the exception in most hospitals, rule in most hospitals? How is it, does the hospital pay for it, charge through the patient's insurance? What are the mechanisms involved?
So do most hospitals have this? The answer is no. But I think after a decade, this is my second book on mediation, if you don't do mediation as part of a bioethics consult service, you at least have to say why you don't. Now, we haven't climbed the top of the hill, and these are non-reimbursable services. So Montefiore has an extraordinary commitment to this service, but hospitals have to find some way to pay for it that doesn't come out of the reimbursement system. Now, we could have a groundswell of people saying it should be reimbursed, as I think it should be, but for the moment it's not.
The privacy issues that involve in
Privacy issues, HIPAA. HIPAA, wonderful. The New York Times projected that $32 billion will be spent by institutions on HIPAA compliance. I'm not a fan of that expenditure. All members of the care team are within the bubble of HIPAA protection. We only meet with members of the care team, and all of the people who are credentialed and work at the hospital are part of that care team. If there is a patient who is capable of making decisions, then we always begin with the patient, and only people the patient wants in the discussion participate in the discussion. But as I said, the vast majority of the consults I do don't involve the interests and rights of patients who are decisionally capable. It's a very good question. Don't be afraid of HIPAA. That's not what some administrators say. Please.